Hi, my name is Matt Rettig. I'm a genitourinary medical oncologist with a specific interest in prostate cancer. My research interests extend from the lab to the clinic and back. And I have been at UCLA and the affiliated VA for over 20 years. So the question is, how do I prognosticate metastatic castration-sensitive prostate cancer? So let's define these terms first of all. So metastatic, that's easy. Patient has a metastasis. Typically, if it's a lymph node metastasis, it would have to be a lymph node outside of the pelvis. In the true TNM staging, an N as in Nancy lymph node is a pelvic lymph node at or below the bifurcation of the common iliac artery, not the aorta. Lymph nodes above that level are M1A. Bones are M1B. Visceral disease such as liver or lung is considered M1C. Castration sensitive essentially means that the patient is newly going on hormone therapy or is already on it and responding, but has not progressed. In principle or in theory, there can be a rare patient who has not yet gone on hormone therapy and doesn't respond, but this is exceedingly rare. So if the patient is diagnosed with metastatic disease and has not yet received hormone therapy, they're assumed to be castration sensitive. There are various prognostic factors, but the simplest way to prognosticate metastatic castration sensitive prostate cancer is based on tumor burden and whether or not the disease is recurrent or newly diagnosed, or de novo, as they say. So de novo metastatic castration-sensitive prostate cancer represent patients who at the time of the initial diagnosis of their disease present with metastatic disease. If they have recurrent disease, that refers to patients who've had some form of therapy to the prostate, radiation, and or surgery, have a remission, and then eventually recur with metastatic disease. Interestingly, in prostate cancer, recurrent disease has a much better prognosis than de novo disease. So we'll go over the numbers in a second, but let's go to the second important category or factor that helps prognosticate. We just mentioned de novo versus recurrent. Now we're going to talk about tumor burden. Low and high tumor burden. Of course, low tumor burden has a better prognosis than high tumor burden. And how do we define high versus low? So high tumor burden is 4 or more bone metastasis with at least one of the bone metastasis outside of the spine and pelvis, so outside of the axial skeleton and in the appendicular skeleton, like the rib or a long bone. We know that those patients have a poor prognosis when they have non-axial or extra-axial metastasis. The other feature that will define a patient as high tumor burden is if they have visceral disease, liver or lung, as the most prominent examples. So if you take these two factors, there are 4 possible categories. They can have 2 beneficial factors, that is low tumor burden and recurrent disease. And their median survival just with standard androgen deprivation therapy only, without adding a second agent, which is sort of what we do as standard of care today, is over 8 years. However, if they have 2 adverse prognostic factors, namely de novo and high tumor burden, the median survival with standard androgen deprivation therapy only is only about 3 years. If they have one of the 2 adverse prognostic factors, the median survival is about 5.5 years, irrespective of which one they have. So that's how we largely prognosticate metastatic castration-sensitive disease, and that's how it's been done in a lot of the phase 3 randomized controlled trials that have asked the question whether or not adding a second agent such as abiraterone acetate with prednisone, enzalutamide, apalutamide, and docetaxel to androgen deprivation therapy improves overall survival. And I'll just briefly say that two of those drugs, apalutamide and enzalutamide, improve overall survival irrespective of the disease burden and recurrent status. Whereas the other two are largely restricted for patients, the benefit is restricted for patients with high tumor burden disease. So chemotherapy and abiraterone with prednisone is most effective for the patients with more adverse features.